Welcome and thank you for joining Southern California Business Report on ABC News and Talks, KMET 1490 AM, 98.1 FM, and KMET TV. I'm Yvette Walker, live blasting our signal from the center of Southern California, serving a population of over 25 million, presented by San Antonio Regional Hospital, here for life. Get us crystal clear and on demand by downloading the free live streaming app on Google Play and the Apple App Store. As always, a huge shout out to the team, Mitch, Bill, and Sean. I love you guys, and to our special advisory committee that can be found at www.scbrtalk.com/advisory committee. Click on the link and learn about the remarkable leaders doing the work. And of course, speaking of leaders, it's always an honor and a joy to introduce Dr. Roger Duber, who is a distinguished interventional cardiologist whose career spans more than 4 decades of pioneering cardiac care and education. A graduate of the College of Osteopathic Medicine and Surgery in Des Moines, Dr. Duber completed his cardiovascular disease fellowship as chief fellow at the world-renowned Cleveland Clinic Foundation in 1983. Since then, he has served as director of the Cardiovascular Service Line at San Antonio Regional Hospital, where his leadership has advanced patient care and innovation. Renowned for his commitment to education, Dr. Duber has delivered over 500 lectures on diverse cardiovascular topics, inspiring peers, residents, students, nursing professionals, and the broader community. His outstanding contributions were recognized in 2015 when he was named Physician of the Year by the Osteopathic Physicians and Surgeons of California. Dr. Duber's expertise, passion for teaching, and dedication to advancing heart health continued to set the standard for excellence in cardiovascular medicine. Dr. Duber, thank you so much for making time to talk about our work in preventative medicine, how to identify a heart attack, and what we need to know as this innovative field transforms before our eyes. So we'll start with an easy one, Dr. Duber, because, sometimes in the day-to-day life and stress and anxiety, we can always think, oh my gosh, I feel chest pains. I feel like I'm having a heart attack. But tell us, what are the earliest warning signs someone might experience when having a heart attack?
Well, first of all, thank you for that introduction. The problem with coronary artery disease is that it's a very unpredictable disorder. Unfortunately, 1 out of 4 people who have heart disease, their first symptom is their last symptom. That's very sobering. So what we try to do is try to screen patients and identify those who are at risk. And if we can do that, we can be proactive and intervene as best as we can to minimize the chances that they will have a catastrophic event in their lifetime. So I would say the first thing we need to do is try to identify patients who are at risk. And there are major risk factors we always think about. One, of course, is age, especially if you've been in practice for more than 4 decades. But besides that, high blood pressure, high cholesterol, diabetes, family history, smoking are the usual major contributing factors. And those are things that we try to obtain when getting a history from the patient. Those are the kind of patients we really want to work hard and trying to screen to see if they are at significant risk. Now, there are a variety of new studies that we can utilize to help us screen better besides routine laboratory studies. But speaking of laboratory studies, historically, we always check the cholesterol and we do a breakdown, a lipid profile, looking at both the high density and low density lipoproteins, which are the good and bad ones, as we call it, plus triglycerides. There are some other newer things that we look at, smaller molecules like LP little a and other certain biofactors that we look at to see if these patients have increased risk for having an event in their lifetime. Besides routine laboratory studies, we have a new type of non-invasive imaging. The first one's been around for many years, and that is called coronary calcium score, where we screen for plaque in the arteries of the heart. This is a CAT scan that takes literally just a few minutes to do. And what they do is they look for calcium in the arteries of the heart. Now, how does that happen? Well, as you can probably see here, this is a normal artery, and there's no evidence of any kind of plaque in the artery.
Mm.
If you look at this one, you can see a little bit of the yellow stuff in there, and that's plaque. Even more so would be this.
Oh my.
So what's interesting about the plaque there is that it sucks up calcium from the bloodstream, and the calcium is embedded into the plaque. So if on the CT scan, I see that there is calcium in the walls of the arteries of the heart, well, then I know they have plaque because there's no way calcium can get into the walls here unless there is underlying plaque. On the other hand, if the score comes back zero, that means that at that time in their life, there appears to be no significant plaque. Now, there are exceptions. The younger someone is, especially under the age of 40 in a male and under the age of 50 in a female, this is less reliable because there hasn't been enough time for calcium to deposit into the plaque. But it can be a very reliable test and help stratify further patients who are low to moderate risk, moderate to high, or the other way around. And sometimes it can be helpful for initiating appropriate proactive therapy, such as statins. So this is a wonderful screening test. Uh, we also now have, as of about 6 weeks from now, we will have the state-of-the-art CTA, which stands for CT angiography. And there we will be able to not only look for plaque, but we'll actually be able to analyze how much obstruction there is within the artery and also determine flow. So not every obstruction needs to be evaluated and intervened. Someone says, well, I have a 70% obstruction, I need a stent. That's not necessarily true. So we can actually measure flow measurements through the arteries with the new machines that we are going to have and determine what kind of lesion would be best to be fixed. Or another way to look at it is this obstruction, even though it's 70%, is this enough that it's causing the patient to have symptoms? So this is a huge step forward. So we not only can look at the obstruction anatomically, but we can also evaluate it physiologically. Is the obstruction significant enough that it's causing a lack of blood flow to the heart muscle? Is it enough that it's causing symptoms? And most importantly, is this something of concern that we need to put a stent or bypass surgery on? So
Wow.
that's very exciting that's happening with this.
That's very exciting. It sounds like a very innovative tool. Do all hospitals have this tool?
Not yet, but I'm sure that this will become the state of the art throughout the country. The CTA that we will have, I feel, is going to be one of the finest machines in Southern California. And we're looking forward to our first patient in about 6 weeks.
Oh my goodness, how exciting. Well, congratulations on that extraordinary piece of equipment that's going to elevate, being able to identify symptoms and signs and physiological impacts. So, Dr. Duber, tell us, are there differences in heart attack symptoms between men and women or among different age groups?
Absolutely. But let me go back one step. As I said, unfortunately, many patients don't have any symptoms, but
Mm.
those who do, the question is, why do they have symptoms? It's due to a lack of blood flow getting to the heart muscle. And when the heart muscle is not getting its oxygen, it tells you that by giving you discomfort, usually, not always. And typically, the discomfort is in the center of the chest, like my hand, and it's over a wide area, not pinpoint like this. It's usually a diffuse discomfort. It will usually last for minutes or longer at a time. It may radiate to the left or both shoulders and down the arms or to the back. It might radiate to the jaw or the teeth. One of the worst heart attack patients I saw early in my training was someone who presented with just a little bit of elbow pain and nothing else, and he had a massive heart attack. So the intensity and the distribution of the pain doesn't necessarily correlate with the severity of the problem. The people you were asking about, are there a difference between males and females besides the usual stuff? And the answer, of course, there is. They do have many times a difference the way that they feel their pain. And it may not feel like pressure in one group and another it will. It may not radiate. So it can be disguised in many ways. So the thing is, especially in those who have risk factors, we need to have a high index of suspicion. And then the toughest group are the diabetics, because unfortunately, 25% of diabetics don't have symptoms. And
Oh
we have
my.
to, yeah, diabetics have an extremely high risk of having cardiovascular events in their lifetime. In fact, a diabetic has as much risk of having a heart attack as someone who's already had a heart attack. So we consider diabetics to be coronary equivalents. So their risk is up to sevenfold compared to a non-diabetic. So we have to be very aggressive in screening these patients and treating them proactively.
So, what course of treatment do you recommend for those that are diagnosed with diabetes as a standard of care to, preemptively keep track of their heart health?
Well, as far as specific diabetic treatment strategies, I probably won't go into that at this time. But in general, I would treat a diabetic as someone who's already had a heart attack. And it still comes down to four things most of the time. One is a good diet. Two is exercising only 7 days a week. Third is a baby aspirin in most groups. And fourth would be a statin. And not only to lower cholesterol, but to reduce cardiac events. So that's where we first start off with, as far as whether it's primary prevention therapy in patients who are at significant risk or secondary prevention in those patients who have already had a cardiac event.
Right. And so for those that sometimes, especially around the holidays, we can indulge, maybe overeat, how can people distinguish between heartburn, anxiety, and a true cardiac emergency?
There's no one answer for that because every single person may have a different representation of their discomfort. And it's very difficult to say you definitely have heartburn or you definitely have a heartburn or I mean, you have pain due to your heart. And the thing is that many times it's going to come down to us, and it can be difficult sometimes to distinguish it. So always try to err on the side of caution in these patients.
So when someone suspects that they're having a heart attack, what is the most important step to take first?
If someone is having discomfort that is sustained, 911.
Mm,
Get the paramedics there and evaluate. And if you don't mind, I could tell you how we take care of these patients.
certainly, please.
Someone has discomfort. We advise them to call 911. Paramedics will come promptly and do an EKG in the field or at home. If they do identify that someone is having a heart attack, the EKG will be sent to the local emergency room that takes care of heart attack patients. We call that a STEMI center, STEMI. And if they concur that this appears to be a heart attack, the patient is brought to that hospital, and the cardiologist as well as the cardiac team are alerted at the same time to expedite them to come to the hospital immediately to meet the patient and initiate appropriate care. When the patient gets to the hospital, they will again be evaluated by the emergency room staff to further confirm that this patient is having a heart attack and confirm that they do require emergency intervention treatment. Once that is accomplished, the cath lab team, as well as the interventional cardiologist, should already be there in the hospital waiting for the patient. The patient is then transferred immediately to the cardiac catheterization laboratory where they are prepped, and we proceed with emergency cardiac catheterization to look at the arteries of the heart. Most of the time, this will prove that the patient has total occlusion of a major vessel that's causing the heart attack. And then we proceed immediately with opening up the obstruction in the artery of the heart with a balloon and stent. Our goal as a STEMI center is that we accomplish this within 90 minutes of the time that the patient called the paramedics from home. That is our goal. That's what we strive for, both here at San Antonio Regional Hospital as well as nationally or internationally. That's everyone's goal. And we're very, very successful in accomplishing that. Frequently, 95% of the time, we are able to do this at our hospital. So,
Wow.
and the
That is
patient frequently will have immediate relief of pain.
That is a great statistic and astounding to hear that from the doorstep of the home to, the final procedure, you're looking at 90 minutes, basically an hour and a half. That is remarkable.
It
Dr.
takes great teamwork from the paramedics to all the emergency room staff, nurses, and emergency room physicians, EKG technicians, etc. And as well as we have a great cardiac catheterization laboratory team that's able to help us expedite care.
Absolutely. I mean, that's what it takes is a well coordinated, well-oiled machine, right? That everyone is synchronized and in perfect timing. It's remarkable how everyone, and I've had the privilege to witness an open heart procedure and the level of synchronicity and communication and timing and just steadiness in the room is absolutely astounding. Dr. Duber, in addition to heart attacks, obviously, what are the most common heart problems you and your colleagues are seeing right now?
Besides coronary artery disease, which we've dwelled on, I would say another very common one are heart rhythm disorders. And this can be many different things. Someone may just complain of palpitations, and palpitations can be just an awareness that their heart is not beating normally. And most of the time, these are benign disorders, but can be very bothersome. Patients may complain of a skipped heartbeat or a flip-flop or a transient flutter. Most of the time, those usually represent premature heartbeats coming from either the atrium or the ventricle, the top or lower chambers of the heart. And almost always, these are benign situations that frequently we can resolve just with reassurance, and most of the time do not require medical therapy for intervention. Some of the more serious ones, which is really now becoming very exciting for our new innovations, is what's called atrial fibrillation or AFib. We see this on TV all the time.
Right.
And atrial fibrillation is when the top chamber is fibrillating like this and doesn't contract, and the bottom chamber can go very fast as well as erratic. So it may sound like bump, 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 bump. So it can be extremely bothersome. So one of the problems with atrial fibrillation is patients don't feel well. The second problem with atrial fibrillation is that it can make the heart muscle weak and cause congestive heart failure. And then the third and worst problem with atrial fibrillation is that it can cause clots in the heart that will then spit out to other parts of the body, most of the time the brain. And unfortunately, the presenting symptom in some people with atrial fibrillation can be a massive stroke. So we try to identify these people, but that can be quite difficult without having symptoms beforehand. So the treatment for atrial fibrillation is, first of all, to control their heart rate. And the second thing is to put them on blood thinners when it is appropriate to prevent the stroke. But how about the patients who have lots of symptoms? Well, we have a lot of different medications to try to control this, but unfortunately, most of these medications are not very effective. Maybe 50, 60% of the time they work, and then you have to take these medications forever, and a lot of these medications have side effects. So it's a less than desirable option in many people. That's not to say that it's not very effective in another group of people, but a lot of people would say, hey, can't we do something else? So we now have, what we've had for many years, actually, for the last 20 years at least, is an ablation procedure for atrial fibrillation, where we put a catheter inside the heart, actually have to perforate the wall of the atrium and basically neutralize the abnormal electricity in the left atrium. Well, historically, this has been a long procedure lasting for 3 to 5 hours at a time. A new technique has come out in the past 2 years called pulsed field ablation. And that has basically renovated how we're treating these patients because it has become much easier to do, higher success rate, and a lower complication rate, as well as a lower recurrence rate. So we're very excited about this innovation, and it's allowing a lot more people to get definitive therapy and avoid lifelong therapy.
So tell us again what this technique is called again.
It's an ablation procedure, and specifically, it's called pulsed field ablation.
Post-field ablation.
PULSED, yes.
Okay, and that's something that you do on a regular basis or
It's
that you're
something
able
that
to provide.
is not that I do. That's usually done. Not, it's only done by electrophysiologists, cardiologists who specialize in heart rhythm disorders, and we do that here at San Antonio Hospital.
Okay, wonderful. So, just quickly, are you finding younger patients presenting with more heart issues than before?
Um, Not necessarily, not necessarily. You still see them from very young to very old. You know,
When's a good time for young people? When's a good age to start getting those regular screenings before they hit the older range, like myself, to start needing regular, ongoing cardiac checkups?
I would say, first of all, it depends on your risk factor, starting off with family history.
Mhm.
If you have family history of coronary artery disease, especially premature coronary artery disease, I would recommend that males in their 30s and females in their 40s start being screened. At least with their cholesterol levels and their blood pressures, the routine stuff to see if they are at increased risk. And at that time, that's when the time when the cardiologist or the primary care physician actually has to intervene by saying you've got to start taking much better care of yourself with diet and exercise to see if we can avoid having to put you on medical therapy for the rest of your life.
Absolutely.
So
One of the things that I worry about, especially as a mother of two teen boys that like to work out, are those energy drinks, right? On the sports, on the field, in the gyms, where they have excessive amounts of caffeine and other ingredients that can accelerate the heart rate. What is a good rule of thumb for those type of supplements?
no energy drinks,
There you
period.
go. No energy drinks. You heard it here. I'm going
You
to
should,
forward this on.
you should get plenty of energy just from working out and exercising regularly.
Perfect. All right, we are coming up on a break, Dr. Duber. Please stand by. For everybody listening, don't Yvette Walker with ABC News and Talk, Southern California Business Report here with Dr. Roger Duber, Director of Cardiovascular Services at San Antonio Regional Hospital, who is leading interventional cardiologist and educator, a Cleveland Clinic trained chief fellow. He's delivered 500 plus lectures and was named 2015 Physician of the Year by the Osteopathic Physicians and Surgeons of California. Updating us on the February 12th event at San Antonio Regional Hospital, Heart to Heart, a conversation on cardiac health in the AIDA Auditorium when we return. Welcome back, everyone. Yvette Walker with ABC News and Talk, Southern California Business Report, here today with Dr. Roger Duber, Director of Cardiovascular Services at San Antonio Regional Hospital, who is a leading interventional cardiologist and educator, a Cleveland Clinic trained chief fellow. He's delivered 500 plus lectures and was named 2015 Physician of the Year by the Osteopathic Physicians and Surgeons of California. He's also going to be updating us about the cardiac lecture that's happening on February 12th at San Antonio Regional Hospital called Heart to Heart, a conversation on cardiac health in the AIDA Auditorium. Dr. Duber, thank you so much for being with us and sharing your expertise. So prior to the break, we left off on the topic of energy drinks, supplements, primarily in the youth. But as we know, the youth are not the only ones using this to perform on the field and, earn those scholarships to go to college, but adults do too. What words of wisdom do you have to share about surrounding that topic?
Well, I would say in general, the more medications you need to take, the more you should try to stay away from supplements or anything else you don't require. Because we just don't have the best knowledge about what kind of drug-drug interaction there may be with the supplements and an essential medication. For instance, let's say you're taking a medication to help stabilize your heart rhythm, and you're also taking a supplement, and it has an adverse reaction where it reduces the excretion of that essential medication for your heart. Well, the levels may become toxic and could even cause a catastrophic event. So many times they cause side effects that we would not normally see. So my rule of thumb is if you don't need it, don't take it.
And if you insist on it, run it past your physician, I would guess.
Absolutely. We have to know everything that you're taking. And I hope that within the next several years, there's going to be great screening studies with blood studies that will tell you, one, if you are at increased risk for having an adverse reaction with drug-drug interaction. Even more interesting is within the next few years with what's called pharmacogenetics, people will be able to know how they metabolize drugs and whether they're at increased risk for having side effects, such as a statin.
Mm, absolutely. Well, Dr. Duber, so we're going to talk about maintaining our heart health. What are your top recommendations for maintaining a healthy heart?
Whether it's for primary care or secondary care, as we spoke about, a healthy diet is extremely important. And there's many different kinds of diets out there. One of the things that I found fascinating during my career was the Atkins diet. Now, the Atkins diet was, all protein, no carb, fat was okay. And, people were coming in and having a steak with a ton of surrounding fat, having it every day. Well, what was interesting about that, we all thought this was going to cause very high levels of cholesterol and increase the risk of heart disease. But paradoxically, what it did was it showed us that it dramatically reduced cholesterol levels, and patients lost a significant amount of weight.
Wow.
And because of that, we've had to readjust our thinking about diet. And that's why nowadays we see things like the keto diet and all these other low carbohydrate diets that have been shown to be very effective, not only in, weight reduction, but also helping depress total cholesterol levels. So that's been very exciting. And, I don't advocate the Atkins diet, but I do advocate some of the good things that we've learned from that diet.
I see. And so, do certain inflammatory diseases contribute, or foods that can trigger inflammatory responses increase the opportunity to develop plaque or to develop coronary heart disease as well?
There's no question that certain foods can be more deleterious to people, to some group of people than others. That's why I try to stay pretty much in recommending a healthy diet like the Mediterranean diet, the DASH diet, that really concentrate on lower carbohydrate levels, plus increasing your fiber, increasing your eating beans, certain types of nuts. All these things we can identify, and they're all very helpful in reducing events.
Wow, that's tremendous. I'm taking notes and I'm going to play this back because I have to make that list when I go shopping. But also tell us, Dr. Duber, why is stress management crucial for cardiac well-being?
Well, the problem with stress is that stress doesn't necessarily cause plaque in the arteries of the heart, but stress can cause physiological torque or stress on the plaque that we were talking about.
Mm.
And that might be the inciting factor to trigger a little bit of a rupture here in the plaque that can cause a heart attack. So stress reduction is good, but how do we accomplish stress reduction? diet and exercise is where I first recommend starting with.
Absolutely. I find just taking long walks is very helpful after a stressful day. It kind of calms everything down and puts everything at ease. And even just getting some sunlight sometimes really
Exactly.
helps with that as well.
One other thing, is, and it's in the same area, is sleep.
Hmm.
We know that sleep is very important, not only to reduce stress, but we do know that people who do not sleep well frequently have higher levels of blood pressure and can be difficult to control without getting enough sleep.
Absolutely. Yes, our circadian rhythm plays a big part of that and having that time for our bodies to recover, right? Also,
Exactly.
another conversation I have with my teenage boys. So tell us again how important regular screening is, and maybe give us an overview of what that looks like in terms of frequency once you do reach that point in time when regular screening is recommended.
So again, we look first of all at risk factors, family history, smoking, high blood pressure, cholesterol, and diabetes. Try to identify those who are especially at higher risk. And then, as I was mentioning earlier, some of the screening studies that we have, certain laboratory studies, not only our lipid panels, but certain things like LP little a can be very helpful. Even if your cholesterol level is normal, if your LP little a is elevated, it means that you still are at significant increased risk for having an event in your lifetime. The coronary calcium score can be very helpful in identifying patients who already have plaque, where we know that we have to be proactive because that plaque is going to get worse over time. So those are some of the things that we use for screening. As far as routine stress testing that we used to do commonly, that probably is not as helpful in people who have no symptoms and who are not diabetics. Because just to show you an example, I'm going to ask you right here, which of these two are at higher risk for having a heart attack?
I would say the one that it looks like has the less flow of blood that can go through. So the one with the smaller opening.
This one.
Yes.
Okay. And that's what we always used to think. And the answer is they're about equal because the problem is not how restricted the blood flow is majority of the time, but what's inside the plaque, how inflammatory it is. And the inflammatory cells, what they can do is start to cause a little rupture or a little fissure in the plaque that induces clot formation and shut off the rest of the lumen. And in fact, majority of patients who do present with a heart attack might have only had a 50% obstruction days or weeks earlier. So that, as I started in the beginning of our talk, coronary artery disease, unfortunately, is an unpredictable disorder. The four things that we talked about earlier, diet, exercise, aspirin, and a statin, all four of those things have one thing in common. They all reduce inflammation
Mm.
in the plaque. And that's one of the reasons why they reduce heart attacks. So, for instance, a statin, yes, they reduce your cholesterol level, but they have what's called a pleomorphic effect on the plaque. They reduce the inflammatory cells and replace it more with collagen so that the plaque becomes sturdier, rubbery, and less likely to rupture. And that's why we usually see a dramatic reduction in heart attack events within the matter of days to weeks after starting a statin.
Oh, wow. I didn't realize how that actually worked within that environment. That's remarkable. It actually changes the composition of the plaque to make it more solid so it doesn't break off.
Exactly. And in fact, there's studies that go back 30, 40 years where we can see a divergence of curves between patients taking statins and not taking statins after a heart attack. Within 30 days, we can see those curves diverge.
Oh, wow. That is a quick change, right? A quick turnaround in outcomes of those cardiac events. So it's no wonder that between your knowledge, your expertise, the state-of-the-art equipment that you are implementing at San Antonio Regional Hospital, your team and San Antonio Regional Hospital has been awarded with several recognitions, national recognitions. What are some of the innovative treatments and procedures available at San Antonio Regional Hospital's Heart Center, leading to it being recognized as a top 50 hospital in the nation for cardiac surgery, Dr. Duber?
Well, we now have multiple different techniques that we are using in the cardiac catheterization laboratory. Historically, we were doing balloon angioplasty. I remember meeting the person who actually started that back in Switzerland, and his name was Andres Grunswig.
Wow.
And he has developed balloon angioplasty back in the late 70s. Within 10 years, we developed the concept of stents that have been developed and modified and are much easier to use and much higher success rate. So stents are the state of the art for patients where we can fix the arteries through the skin. Some of these obstructions have become increasingly difficult to work with, and we have all different kinds of tools, such as small drills and what's called lithotripsy, something similar to what's used for kidney stones, but where we use that device to help pulverize calcium within the plaque. And then we also have laser atherectomy, where we go in and actually use laser to create a channel so that we can get a stent into the artery. So the tools that we have really improved dramatically over the last decade.
That is remarkable. And I know that's just one of the awards that you have recently been recognized with, but what are some of the other ones that are basically, filling the halls of the hospital with these awards and recognitions for the cardiac center?
Well, we also have devices that help stabilize a patient. Unfortunately, some patients, when they have a heart attack, they come in, we'll say, a little bit too late to the point that their heart muscle is hardly moving. But it can be revived if we have the time. So we have devices such as what's called a balloon pump, or even now a better one, we'll say, called Impella, where we put a device inside the heart going through the groin and then help improve blood flow going from the heart to the rest of the body so that the heart doesn't have to work very hard to get the blood out, to buy us time to help restore blood flow to the heart muscle itself to improve the chances that a patient can recover from their event.
That is remarkable. How does the hospital's chest pain center accreditation and STEMI receiving center designation impact patient care?
Well, obviously, we feel that by us being able to reopen these arteries 95% of the time within 90 minutes, that we are significantly improving the patient's prognosis. Historically, back in the 60s and 70s, if you had a heart attack, you had up to a 30% chance of not making it.
Oh, wow.
Nowadays, it's down to about 3%. So we've really come a long way with everything we are doing. And it takes a lot of teamwork to do that by having a STEMI center and everybody willing to contribute to make this successful.
That's remarkable. And so looking ahead, what advancements or initiatives can we expect from your cardiac program to further improve heart health outcomes, if that's even possible, right? Making that 3% to 1%?
Time will tell. Time will tell. Uh, Another innovation, if we have a minute, I can
Of
talk
course.
about
Yes.
that's very exciting, are pacemakers.
Hmm.
Pacemakers back in the 60s and 70s, we actually went through the abdomen initially. And
Right.
then later on, we were able to go through the vein, but the generator was about that big. And it was a big hole underneath your skin. And over time, with miniaturization, just like computers, they've gotten progressively smaller. But you still had to go through the vein, and that has its own potential risk and complications. There's a new kind of pacemaker that's been out for several years. I was fortunate enough to do some of the early research on it, where we actually deposit the pacemaker inside the heart. We go through the groin and it has tiny little prongs, and it's about that big only. And we actually attach it to the inside of the heart, take everything else out, and it's there for the next 10 to 15 years.
That
It's
is remarkable.
it is remarkable because these pacemakers are wonderful and they don't have any other hardware inside the veins or anywhere else.
That is just amazing. And so these are all the topics that you and your cohort of cardiologists are going to be discussing at the upcoming event, Heart to Heart, a conversation on cardiac health, which is taking place on Thursday, February 12th at San Antonio Regional Hospital in the AIDA Auditorium. Dr. Duber, tell us about the upcoming event and what the community can expect.
We have four great speakers, and the way that we're going to do this, each of the four speakers will, over 10 minutes, give you some pearls of education in various different topics. And then at the end of this, we'll have a question and answer period to explore further their topics or any other cardiovascular events. So we'll have at least 20, 30 minutes where the audience will have plenty of time to really dive into these various different subjects. And then afterwards, we're going to have question and answers with the individual cardiologist by posters in various portions of the room. So there's plenty of time for everyone to, get to meet the cardiologist and talk with them.
So, who is this event designed for? Is it for patients, families, healthcare professionals, or the broader community, or all of the above?
All of the above, yes. Yes, I think everyone's going to appreciate this. It's not a lecture that's going to be putting you to sleep. I think everyone's going to enjoy this. I think they'll have fun, and we're also going to have extra things there to make it even more enjoyable. Some certain treats that are going to be provided by the hospital that are, of course, heart healthy.
Wonderful. And so, how can people participate or sign up for the event?
These are events, if you go online for San Antonio, it's being broadly advertised. And I would say if you want to come, hurry up and do it because we are getting very close to capacity already.
That is exciting. Yes, it's going to be Thursday, February 12th. Heart to Heart, a conversation on cardiac health with a handful of leading cardiologists, including Dr. Duber. Dr. Duber, you will be moderating the event. This event's been taking place for quite a few years now. What do you look forward to the most as you moderate and interface with the community?
I would say the most fun thing is watching patients or watching the community learning and enjoying it. It should be an enjoyable experience, and I'm sure it will be again.
And so, what do you hope attendees will take away from these lectures?
Oh, I think that they'll have a better understanding of cardiovascular disease. We're going to be talking about preventive heart disease, women and heart disease. We're going to talk about some of the things we touched upon today, including the newer imaging techniques, as well as some of the newer techniques we're using in the cardiac catheterization laboratory to help restore blood flow to the heart.
Well, that is very exciting, Dr. Duber. Thank you so much. I look forward to attending the event. And as you mentioned, details for the event can be found on Eventbrite under Heart to Heart, Conversation on Cardiac Health under San Antonio Regional Hospital, as well as San Antonio Regional Hospital social media platforms, including Facebook and LinkedIn, and on the website. Anywhere you go, related San Antonio Regional Hospital, you will see it highlighted because it is an annual staple event that everyone looks forward to. Dr. Duber, let's close with some of the feedback that you get from the community that have the opportunity to go and attend and interface with top tier cardiologists such as yourself.
I think that the patients or the community members that have attended have consistently enjoyed it. They've gotten things out of it. And a lot of times, this is the best part is they've changed their way of life. They're eating better. They're exercising more. They're being more attentive to symptoms that may be of concern. They're seeing their physicians and saying, I think I'm at risk. So those things are all very helpful and
Well,
spreading the word, of course.
of course, spreading the word, of course. Well, that's the key, spreading the word so that everyone has the opportunity and access to the critical education necessary to have that enhanced quality of life so that we know what we need to do to be aheart of our heart health and not get the symptom that is incurable. So, Dr. Duber, thank you for your insight. Thank you for your expertise. And as always, thank you for sharing your knowledge and your talent with our community.
Always a pleasure. Thank you.
Wonderful. For everybody listening, don't forget to find us on Facebook, YouTube, LinkedIn, and Instagram. Check us out on scbrtalk.com. And don't miss my conversation with San Antonio Regional Hospital's unveiling of Urgent Care Plus in Ontario, an innovative center for all stages of life, treating mental and behavioral health. Guided by CEO John Chapman and LCSW Dominique Salido, this groundbreaking program sets a new standard, blending compassionate expertise with visionary leadership to transform community care. Next week, we will have Zeb Wellborn, President and CEO of the Chino Valley Chamber of Commerce and 2023 WACE Executive of the Year, transforming the Inland Empire through award-winning economic innovation, business resilience, and public-private partnerships, while redefining leadership and growth as a dynamic marketer, speaker, and community builder. We will see you all next week. You do not want to miss it.